The next nucleic acid synthesis inhibitors are quinolones and fluoroquinolones. The first quinolone was nalidixic acid. It was actually a urinary antiseptic against E. coli, Proteus, Klebsiella, Enterobacter, Salmonella, Shigella, but not Pseudomonas. Then, fluorinated analogues of nalidixic acid were developed, known as fluoroquinolones, which had activity against Pseudomonas as well. They include norfloxacin, ciprofloxacin, peflofoxacin, levofloxacin, gemifloxacin, and moxifloxacin, etc. Their mechanism of action involves the inhibition of two enzymes that are required for DNA replication to go smoothly. First is the topoisomerase 2, also known as DNA gyrase, and secondly, topoisomerase 4. Topoisomerase 2 actually removes positive superhelical twists that arise after helicase unwinds the DNA, while topoisomerase 4 allows the two newly formed chromosomes or DNA molecules to come apart after DNA replication. Fluoroquinolones inhibit topoisomerase 2 in gram-negative bacteria and topoisomerase 4 in gram-positive bacteria, and thus inhibit bacterial DNA synthesis, so they are bactericidal in nature. Resistance to fluoroquinolones is emerging and increasing day by day. Coming to their antibacterial spectrum and their uses, they have high activity against gram-negative organisms such as E. coli, Enterobacter, Proteus, Klebsiella, Salmonella, Shigella, H. influenza, Neisseria gonorrhoeae, meningitidis, cholera, and Campylobacter jejuni. It also has activity against Staph aureus and Pseudomonas aeruginosa, as I previously mentioned, and also Mycobacterium tuberculosis. Their uses include their use in UTIs, and fluoroquinolones are the most commonly used agents for UTIs, and they are superior to cortimoxazole. They are also used in bacterial prostatitis, just like cortimoxazole. They can be used to treat sexually transmitted diseases and pelvic inflammatory disease associated with chlamydia and gonorrhea. Skin, soft tissue, and bone infections by gram-negative bacteria such as Salmonella can also be treated. Diarrhea due to Shigella, Salmonella, E. coli, and Campylobacter jejuni is also treated with this, and drug-resistant pneumococci are also treated with this. Also, ciprofloxacin is preferred for the treatment and prophylaxis of anthrax. Regarding the pharmacokinetic properties, they also have a food interactions just like tetracyclines, and their absorption will be inhibited or decreased by antacids, calcium and iron ions or salts, milk, supplements, vitamins and minerals, etc. They can also be used IV or topically, and they are excreted renally, so their dose should be adjusted in renal patients. Lastly, their side effects are mostly associated with the GI tract, that is nausea, vomiting, diarrhea, and discomfort. CNS effects can include headache, dizziness, hallucinations, and even convulsions. There are also hypersensitivity reactions, and phototoxicity is also there, just like sulfonamides. A classic side effect is tendinitis and tendon rupture, especially in athletes, and this is because it gets deposited in the tendons. It can also cause prolongation of the QT interval, leading to torsade rhythm. It is contraindicated in pregnancy and also in children because it will cause decreased chondrogenesis in children. Some drug interactions are that they will increase the plasma concentration of theophylline, warfarin, etc. by inhibiting their metabolism, and NSAIDs actually potentiate the CNS side effects of fluoroquinolones. That's all.